incidence rates to plan. Okay, now let us look at measures of mortality. We talked about morbidity being either disease or, or departure from health, disability. Mortality is about death. Mortality is about death. So what is mortality? It refers to the number of deaths, particularly on a large scale in a population or geographical region area that is being studied. It's expressed in terms of death per 1,000 population of people. So why are mortality rates studied? Why do we study mortality rates? One, mortality rates are studied to know the prevalent causes of death among the population. So when we know the particular number of deaths, when we see the number of deaths in a population occurring because of one particular reason, then we are most likely to know what to do in terms of intervention. That is why it's very, very important. Then, once identified, scientists could make the general public aware. So if we know that people are dying from any particular disease, then we can communicate to the people and tell them preventive measures and all that. Okay. Also, it help us to take a look at the quality of life of our people. If people are dying, we begin to look at the quality of life. Why are they dying? Okay. So the accurate measure and estimate of mortality levels or mortality trends or mortal causes are different. They are different. So the preferred sources of mortality data, usually mortality data we get from either civic registration, that is maybe from national population, where we do registration of deaths. Okay, we can also through our health facilities. And those ones, even in communities, are encouraged to, even if somebody dies at home, he's supposed to report to the health facility and death certificate to be issued for civic registration. But in many countries, especially those with poorly developed statistical system and higher levels of mortality, retrospective measurement in household and surveys is the vehicle they use. Where we're unable to do real-time registration of deaths, we begin to do survey and go and, with time we go to places and ask, in the past 1 year or in the past 5 years, how many people have died in your family? Just trying to get in retrospect what happened in the past. Okay, we do that also, but like now in Nigeria, because of our own National Population Commission, we do real time. All forms of data collection, of course, they suffer from some sort of error, either incomplete data or dating error, particularly if it is retrospective. People may not remember very well, they can give you a wrong date. So let us look at the types of mortality rates. There are many. Crude death rate, age-specific death rate, maternal mortality ratio, mortality in early life, proportional mortality by cause, proportional mortality by age, specific cause, and so many. So I have put all there, but I will jump some of them because in practice, you don't need all, but you just have to know it. Let it just be that you have an idea about what it's doing. So crude death rate is defined as the total number of deaths in a calendar year per 1,000 media estimated population, approximately the average population exposed to risk of death during the year. Okay. The total number of deaths registered over P is your media population. We talked about this media 1st July and the constant, right? The constant either 1,000 or more. Okay, so advantages, we use crude death rate shows the level of mortality in entire population, usually index of mortality found in our general statistics. Even where a detailed analysis is contemplated, crude death rate often gives a preliminary indication of the level or trend of mortality. Delimitations. It mixes together all population groups, all whose mortality varies widely, whereas majority result of mortality study have come from examination of those in different from different components. So the major limitation is that it combines the mortality of everybody, old, young, sick, well, sick from different diseases, dying from heart attack, dying from cancer, diabetes, heart disease, whatever. You know, that is, those mix is a problem. It doesn't help us, you know, even in planning, because it's so much mix up. It's not teased out. Because it's not teased out, it becomes difficult to use it. It mixes everything in this. So weakness for international, you cannot use, not even for even local comparisons. You can't use comparison. You remember I told you when you say 15 persons per thousand, you know, 15 per thousand in River State and 12 per thousand in Abia. You can't really compare it. We don't use it for comparison. You can't. If you want to do comparison, you must standardize those rates. That's only way you do it. Okay. Then age-specific rates, better. So this one is the death of population, either particular age group during a year. You see, here you can say death of people under 5 children, neonatal deaths, and things like that. So here, age-specific death rates or age death of, you know, any particular group according to age. So advantage is advantageous to prepare those rates separately for males, for females, age and sex-specific deaths. The only mean of calculation of age-specific death that is unaffected by age the only mean of calculation of age-specific death rate is unaffected by the age composition of the population. Now look at example of specific deaths. Age-specific deaths, for instance, specific deaths in age group 15 to 20, number of deaths in age 15 to 20 over the media population. At times, specific death rate, we use it for many reasons. Use it for many reasons because it's important for our demographic data. If age-specific death rate among young people begin to get high, the society begin to look at things like accidents, things like drug use, and all that. So, or age-specific death for TB and all that. So, these several examples of age-specific deaths. Specific death due to TB, specific death due to for males, specific death for so various age groups. So you can look at that. Then you see maternal mortality ratio. The number of define the deaths of women while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of the pregnancy, from any cause related or aggravated by pregnancy or its management, but not from accidental or incidental causes. So maternal mortality ratio is any death that is related to that pregnancy or conditions associated with that pregnancy, not death from violence or accident or any other thing. Okay. So the risk of maternal mortality ratio, say risk of dying from causes associated with childbirth is measured by that maternal mortality ratio. So this is that definition that's expressed. Now look at this. See this slide well illustrates. I got it from one of your books I gave to you. I like it because it's pictorial illustration of maternal mortality ratio and maternal mortality rate. You see, now look at maternal mortality ratio. The numerator is maternal deaths, right? And the denominator is live births. You see, that is why it's a ratio. The numerator is not part of the denominator. So here, the numerator is maternal deaths, and the denominator is women of reproductive age. You see, women of reproductive, these deaths among women is from these women of reproductive age. So the numerator is part of the denominator. So this book very much illustrates it very well. Then there are other mortalities in early life. These ones will be better for clinicians. So what, maybe, I don't know, since you came here wanting to study, this one will be better for clinicians, like stillbirth rate, perinatal mortality rate, early neonatal death, late neonatal death, all forms of neonatal death, then post-neonatal death, infant mortality. But for you, what is most important is the infant mortality rate, because in public health, we use infant mortality rate and neonatal mortality rate. These two, infant mortality rate and neonatal mortality rate, we use it to look at the socioeconomic conditions of the country. It affects the. So look at infant mortality rate. Mortality rates among infants. Who is an infant? So you can see who an infant is. From the time of birth to when the person is 1 year is an infant. Many times we just mention this without us knowing the details. Or who is a neonate? Neonate is somebody from the day of birth to 1 month. That's a neonate. Okay, so infant mortality, neonatal mortality is important for us in public health. The other ones, the clinicians can look at other one, the rest. So infant mortality rates, so it's a mortality among infants, and it's of special significance, one of the most sensitive index of health conditions of the general population. So if we want to measure, it's one of the measures we use to tell about health conditions of a country. So if you want, there's no way you can write the profile of Nigeria without mentioning the infant mortality rate or under 5 mortality rate. It's not possible. If you do that, the health profile of Nigeria is not complete. It's the most important sensitive index we use, infant mortality rate. So how many children are dying before the age of 1? Because it tells a picture of the healthcare system of the country and the social conditions of the country. While neonatal mortality rate tells more about the health system, the infant mortality rate tells about both. Okay. So infant mortality rate is calculated as the ratio of the number of deaths of infants under 1 year of age to the number of live births occurring in that given year. Okay, that's infant mortality. Then you have one. These are the methods you calculate them. These are the methods you calculate infant mortality rate, infant mortality. So the number of deaths, children under 1 year among the population of that particular area over the live births. Okay, infant mortality rate. Then the significance of our infant mortality rate. the significance of infant mortality rate. It is the most single measure of health status of a population. It is the most single measure of our, of our population, the most single measure of our health status of any country. Infant mortality rate may be very high in countries where health and social services are poor. So if our infant mortality rate is high, we know that health and social services are poor. The other one is neonatal mortality rate. It's the deaths between the age from birth to 1 month to 28 days is classified as neonatal mortality rate. Okay, neonatal mortality rate is related to problems arising during pregnancy. Example, if there's congenital abnormalities, low birth weight and all that. It can happen where there are birth injuries, asphyxia. That is why I'm talking about our healthcare system also. Or after delivery, things like tetanus or other infections. When the healthcare system is weak, you see things like children getting infected at the point of delivery. So here it talks much about our healthcare system. Okay. Then the rest, post-neonatal mortality rate, well, these ones, post-neonatal mortality rate talks about, just like infant mortality rate, gives you about the health conditions of the country, including environmental factors, poor child care practices by parents, lack of access to health care. So those are, then perinatal mortality, that is around birth. Okay, mortality around birth. Those ones tell us more about the quality of our healthcare system. Are we able to diagnose fetal distress? Are we able to do something? Do we have neonatologists? How developed is our neonatal medicine? In fact, let me shock you, I only know one trained and qualified neonatologist not Port Harcourt now, River State. A neonatologist. All right, these ones I told you is better for a clinician, but you can just read it for your interest's sake. Case fatality, I told you we use it to measure disease severity. And case fatality is number of deaths assigned to a specific disease over the number of cases of that disease. Okay, this is another one. This is not popular. It is called by one Raymond Pearl, the ratio of the total number of births to total number of deaths. Okay, or the vital index. For every birth, how many deaths? And, we also use it to look at the level of development on our reproductive healthcare services. A woman cannot be giving birth and the children are dying. It talks more about a lot of the weaknesses in our healthcare system. Then under 5 mortality rate too, okay, that one is similar to infant mortality rate. It talks a lot about our healthcare system and the total number of under 5 children in a given year and locality, and total number of live births in that same year. So the variables here that are affected include poverty. Children can die from malnutrition, poverty, poor education of parents, particularly of mothers, availability, access, and quality of health services. Health services might be available or might not be available. And if they're available, do people have access to it? Are they paying out of pocket? Out of pocket expenditure pushes families to what we call catastrophic healthcare expenditure. When they spend a lot of their income to take care of health and thereby neglecting other things. Environmental risks, including access to safe water, sanitation, and nutrition. Okay, child mortality rate is there. So that's all. Thank you. Okay, let me look at the time I have. I have 30 minutes. I don't know whether I'll use this for questions or I use it to do some other things. What do you think? Okay, so I have 2 hands raised already. Oh, 3 self. All right, Zubairu, Umar, go on, unmute yourself. So please, you can unmute everyone and let them ask questions. Host, unmute everyone. Okay.
Hello, good evening, sir.
Good evening.
Yes, sir. Thank you, sir. So
See the problem of omitting everyone.
That's the problem. And when they will not listen, when they listen to the lecture, they will ask me questions. Now, they will not listen to the when somebody will not listen to the lecture, I will begin to ask questions. How will you answer? Just put down your hand. I'm not answering your question. John, not here, please. I'm not answering his question. That shows that, look at the type of noise at his background. They want to ask me a question. John, can you ask your question? Beg, not have time for that. Please ask.
Okay, sir. Good evening, sir.
Good evening.
And thank you for that beautiful lecture. It is explicit enough. So I want to know, you said mid-year population.
Yes.
We use the 1st of July of every year when you are calculating it. Is it also possible for us to use?
So,
I mean, we use, can you hear me, sir? Now, we said the mid-year population, when you are calculating it, we use the 1st of July of the given period of a given year in calculating it. I want to know, is it also possible?
Hold on, your network was breaking, so I didn't get the whole question. No? Can you repeat it now that it's better?
Okay, sir. I mean, in your explanation, sir, you said when you are calculating mid-year population, you make use of 1st of July of a given year, particular year.
Yes.
Is it also possible we make use of the 1st of January of a year and the 1st of December, you multiply it together and divide it by 2? Can we also use that formula, sir?
Don't use 1st July. The 1st July is a global assumption. When you introduce your own, you have spoiled something. I am not the one that introduced 1st July. It's what is adopted globally. Do you understand? So it is something in science, in public health, has been recognized. WHO, everybody, so don't deviate from it. Except you are such a scientist that with your own this and you convince the world that then before they can change. All right, go on. Next person. Who is next? Sorry. Augustina. Okay, is it Augustina herself? I don't know. Sorry. Is it Polycarp? Polycarp, then because this is changing. Polycarp, Jerry. Go ahead.
Good evening, Prof.
Good evening there.
Please, Prof, I didn't get the explanation of ratio.
Ratio. I'm saying, for instance, if in your office where you work, for every 1 man, there are 3 women. Assuming you have 3 males and 9 women in that section, it means for every 1 man, there are 3 women. That is a ratio because men and women are different. That is a ratio. For every 1 white blood
Thank you,
cell,
Prof.
there are 600 red blood cells. For every 1 doctor, there are 5,000 Nigerians. That's a ratio, doctor-patient ratio or doctor-population ratio. Or for every 1 nurse, there are 15,000 or 18,000 Nigerians, something like that. So that's a ratio. Okay.
Okay, Prof. Thank you,
Yeah.
Prof.
Jerry, go on. Okay, if I do. Oh, okay. Well, the names are now, there are so many. Jerry, can you go on? If not, okay, let's get Tebepa.
It's not,
Tebepa
hello, sir. Jerry is online, sir.
it's okay now. I was
Yes.
calling.
Concerning infant mortality and under 5 mortality ratio, the factors are there. Can we compare it to child killer diseases? He said one of the factors
Yeah.
they are using is poverty, environment,
Yes.
but immunization is not mentioned, sir. Is it part of the childhood killer indicators we can use in the country that a proper immunization has been done or not?
Proper
Immunization.
I know, I understand your question. Proper immunization or not is part of health sector. When I say the health sector is weak, a health sector that is weak, maybe there's poor immunization services, poor manpower training, few health personnel, or some health center that open once a week healthcare system. So immunization is going to micro details. There can be health centers that there are no drugs, and so those are just this thing. I don't know whether you get what I mean.
Yes, I do,
One
sir.
can use health service, the healthcare delivery service as a whole to cover it.
Okay.
Immunization is one of the things they do. They also give drugs. They also treat people to give drugs. They also do delivery. If all of them are weak, is the healthcare system is weak. That's what I mean.
Okay. And lack
All right.
of proper professional manpower.
Yes, they are all part of it.
Okay.
The health system is made up of the structure, the management, then the processes. The processes, how is it run? How is it managed? You see, so those are all of them.
Thank you, sir.
Thank you. Tebepa. Tebepa, can you, Jesudia, Augustina, can you unmute yourself?
Thank you, sir. Good evening, sir, and thank you for that
Yeah.
very wonderful lecture. This is Tebepa speaking.
Thank
So
you.
my question, sir, when you explained incidence rates using measles, you said
Yeah.
something about the immunized people not being at risk, and
Yeah.
it got me a bit confused.
Okay.
So when we
Oof. Oh,
going to subtract the immunized population
exactly.
from the total population, let's say under 5.
Yes.
Are we now going to subtract the immunized population, or we are using that under 5?
No, you are going to remove immunized population because they are not at risk. For instance, somebody who is not flying is not at risk of crashing.
As the denominator.
You only use only people at risk. Only people at risk. So when you are calculating that, you will use unimmunized people only. Unimmunized. What population is unimmunized? That population is the base population you are going to use. Okay, Philette Kunu. Philette Kunu. Okay, Adam Suleiman. Adam Suleiman. Somebody is asking whether incidence, can incidence be like point prevalence? No. Incidence is new cases of a disease. Prevalence is old and new, all put together. The old ones, new ones are coming, all existing together. You talk about prevalence. So they cannot be the same thing. Thomas,
Good evening, sir.
Good evening.
Okay, so this is Philette. Sorry, I'm trying to get clarification. You talked about perinatal mortality rate and perinatal mortality ratio. Please, can you just a little clarify me on that, the difference? The perinatal mortality rate and ratio. Thank you, sir.
Okay. Let's
Mortality rate.
Ratio.
The ratio is male to female.
Why, when you are talking about the rates, you are talking about the severity, it is mild, it is
The number.
The number.
okay.
Totality.
Okay.
Some of them no, now just sabi.
Please, let's have one.
The
Total number of live births.
They know.
Some know.
Some
Please,
no.
let's have.
I know that because me, I call Luke Seb, I go through the lecture, not to understand. So what I will ask. Don't say I will rest my hand. You know, you say Adam.
Please, let's, okay, here you have defined as the number of stillbirths. That's stillbirth or late fetal death, and the infant death under 1 week, 7 days. So you have stillbirths under 1 week in the population, total live births, the same population, right? Okay. Now, the number of live births. Okay, this is number of live births, same population in the year. This is number of deaths under 1 week. Oh, this is early neonatal death. Oh, sorry, it's not the same. Late neonatal death, perinatal. Okay, it's just live births, okay? You just take it, call it, it's number of deaths, right? Stillbirths and death over total number of live births. That's why it's a ratio. C, stillbirths are dead children. Death under 1 week, they are all dead. Then over live births. Do you understand? Over live births. If it is a perinatal mortality rate, it will be those who died over all the ones that died. So is here, the difference here is stillbirths, that's children that born dead, and those that born alive but died within 1 week. Over all the children born alive, the same period. That's the perinatal mortality ratio. Okay. If you are looking at perinatal mortality rate, as I told you, the rate is the numerator is part of the denominator. So that will be over all deaths. Over all deaths. Okay. Over all deaths. So the numerator will be over the denominator. In fact, I have to leave at 9. I'm sorry, at 7 because I have another meeting. So if you have to ask questions, we'll have about 20 more minutes to do so. Onyinye, Tonyona, Onyinyechi, please ask questions fast.
Okay, good evening,
Time.
Prof.
Yes, please.
Thank you so much for your
Thank you. Just go on.
lectures.
Thank you very much. Go on, please. Go
Okay,
on.
when you want to calculate death rates,
Yes.
when you want to calculate death rate that, okay, when you want to calculate death rate that involves a mid-year population.
Yes.
Prof, please, can you hear me, sir?
I can.
I said when you want to calculate death rate that involves mid-year population, and when you want to do these surveys, let's say sometime in say this year, this month, and we are not yet into the mid-year of July.
Yes.
Can you use the mid-year of the previous year to now do the calculation?
Yes, in as much as you can prove that is the media population. The reason is that if you use any other thing that is not media population.
Of the previous year.
Yes, if you use anyone that is not media population, it will be faulted. Because it is something that has been adopted by convention. So there will be questions, yes.
Okay, thank you so much.
Somebody said, is there no time specification for case fatality rate? There is. Once there is a rate, you see, case fatality can vary from year to year. Maybe 100 people got measles, 2 died in 2022. In 2024, 100 people got measles, none died. In 2026, 100 people got measles, 5 died. So the case fatality rate, once it's a rate, there is a time specification. Please. Can we say malaria disease is prevalent? Wait, hold on now. This difference between, I'm not answering the question of difference between incidence and prevalence. You can read it up, okay? You are noise. I don't know, you are in town hall meeting and you are coming to ask me after I spend my time. Please
I have a question, Prof. Sir.
Asking me to explain the difference between incidence and prevalence that I've been shouting for 2 hours.
I have a question.
Please go ahead and ask.
Hello, can I ask my question?
Go ahead, I'm listening. Go ahead.
Okay, good evening, Prof. This is Dr. Mari.
Please go on.
Yes. You talked about the fact that illnesses are sometimes only recognized when signs and symptoms become obvious.
Yes.
Now, considering that our situation, the local situation in Nigeria, it's in many cases, a lot of illnesses go unrecognizable until the symptoms are out. Yes. So how can this concept of spectrum of health and diseases be helpful? How can it be used to, strengthen maybe early detection or preventive health strategies in our system, in our healthcare system?
Sorry, just repeat that. I understand what you have said. The question, how can that from their network?
How can the spectrum of health and disease, which you just explained, how can we apply it to strengthen early detection and prevention health?
Yes, spectrum of health or spectrum of disease is just saying that a lot of disease are unrecognized. Some are mild, some are very severe and complicated. So it's just saying that disease flow in a great range, a range. Some are not even detected at all. Some are mild, others are severe. So it's just trying to tell us how the spectrum, just talking about the linear. If you spread it out, some are severe, some are mild, some are even undetectable. That disease vary across this spectrum. Not all cases of disease are severe. Not all cases of disease are mild. Not all cases of disease are not obvious. So you're just saying that disease spread, it goes across wide spectrum. Some are not obvious to us. Some are mild. Others are severe. That's the spectrum. If you put it in a linear, in a long line, that's just what that spectrum means.
Okay. Yes. So how do we make it practical, sir, to maybe strengthen our healthcare system so that,
Now, if you want to strengthen your healthcare system, for instance, those ones that are not detectable, not detected, it doesn't mean because they are, it's not because they are not there. They are there. The only way we can detect them is to apply, things like screening. Because one of the ways to detect unrecognized disease is screening. When you screen it, as I also mentioned along the line, there are many people going about not knowing that they are hypertensive. So when you put that spectrum of hypertension, you can see that there are undiagnosed cases of hypertension, there are mild cases of hypertension, and there are severe cases of hypertension. That's the spectrum of hypertension. So if you want those undiagnosed cases to be recognized in the healthcare system, we need to diagnose, to apply screening tests so that we recognize them. Okay? When we apply screening in our various populations, then we'll detect those who have been going about not knowing that they are hypertensive. Now they have known, and now they are taking measures against the disease. We also treat those who are mild and those who are severe. I don't know whether what I've explained is in line with the, except I'm not understanding the question you are asking.
No, perfect. You've answered well, sir. Thank you, sir. I appreciate it.
All right.
Okay, Prof.
Hello, Prof. I want to contribute something to this of Dr. Maria.
Yes, please.
Yes, sir. She was in terms of helping to discover some of these undetectable diseases. So there are system-based efforts and there are patient-based efforts.
Okay.
Yes, yesterday you were talking about modes of intervention. You see, some of this intervention can be patient-based effort, for instance, or health professional-based efforts. When you educate people, you see that that's when we now start talking about health-seeking behavior. You see, the health-seeking behavior of people improve because most of these cases, these people do not appear in hospital. They do not come, and it's when they come that some of these things are assessed. So you see that some of those illnesses, mainly the non-communicable diseases, they remain undetected, and that's the only way. So why there are still health system-based efforts, which is to assess, have the equipment and making the health services accessible to people. Yes, sir.
Yeah, I agree. Very correct. Very correct.
Yes, sir.
Health education. I say very correct. At times you can see, many times you hear that you see somebody doing radio program, and you see somebody giving health talk. In our department at UPTH, I remember very vividly, we saw a TB patient, and when we tried to know how he came for screening on his own, and he was diagnosed as TB. And he said he heard about it on a radio. He heard about it on a radio program. it happened that normally we do, where our residents are rostered, they do radio talk. Maybe one hypertension day, somebody will go to some of the radio stations, phone-in program, people will ask questions and like that. So it was a World TB Day, and normally we had that week, we make sensitization. And it was through that sensitization effort that the man is a welder and heard about the radio program and now decided to come for screening, and alas, he had TB. You see, so what you are saying in a nutshell is very correct. Through health education, people can now, also make effort. Maybe what this person explained appeared to be like what I've been feeling. Let me go for checkup. And it turned out to be what the person was. All right.
I also have a question, sir. Sorry.
Please be fast. I'm leaving in the next 5 minutes. I told you people I have
okay, sir. Sorry. When you talked about the types of rates, you talked about crude rate, specific rate, and standardized rate. So what are some of these criteria of standardization? What are these factors of standardization?
Well, we have direct standardization and we have indirect standardization. That's it's just that I didn't want to bother you, but I can teach you standardization. It's just computational. I will bring a lot of confusion. That's why I didn't bother about it. And I know that most times you might not need it. If not, in fact, it's one of these things I even have, on ground, actually. So there is, you see, let me show you one of this thing. I have this thing I would have bothered to actually, but I just felt that it will bring us too many. Oh, what's happening? Okay, sorry. So you can see it. There are ways you can standardize rates, but because I'm looking at the nature of class we have, it's going to bring us a lot of confusion. I decided to be silent on it because many times you might not also need it. If not, I can teach you standardized mortality ratios and all that, but you will ask questions from now till next tomorrow. That's the problem. So I felt that I wouldn't need to bother you with it. All right, so that's it. Okay. Just deliberately it. Uchechi.
Okay, sir. Thank you, sir.
Yeah. Uchechi Udonsi. James Odo. Okay, I think at this point I will see you tomorrow. No, not okay. For now, my lectures until next week. I have a few more lectures when I came back from my journey. So from next week, Professor Maduka will come on board, and from Monday. So that's so good night, please. I have another meeting. I have to. It's like the meeting is at 7. It's called to order. So I'll see you next week. All right, our upper week. All right. Good night. Thank you, everyone. Or if you have your questions when I come next time, please, you can ask. You can ask. Just write it down so that you don't forget. I will answer. Thank you and bye.
Thank you, sir.
Thank you so much, sir.